In 1995, I suffered an eye disability to my right eye, which really forced me to sell my practice. And so since 1995, I've converted over full time to what I'm doing today.
Good evening, everybody, and welcome back to the Dental Implant Podcast with me, Pav Kara. And I am actually very honoured to have Paul Homoly on as a guest today. So,
hello, everyone.
Hi, Paul. How are you doing?
I'm good. I'm sitting here in close to Scottsdale, Arizona. It's 90 degrees outside. I'm glad to be in here with you.
Fantastic. So, Paul, you and I actually go back quite a few years.
We do.
In fact, I had communications coaching with you when I owned my own practice many, many years ago. And I was actually recommended you by a friend of mine on Dental Town, Michael Melkers. He goes by Miguel. And,
sure, I know Michael.
Yes, he's you know, I need to get Michael on this as well, because he's a fantastic guy to listen to as well. Very, very knowledgeable. So I was having problems because I was quite young when I bought my practice, and my philosophy was, if I do great quality dentistry, that patients will be lined up around the block waiting to have this type of work done. And I realized very, very quickly that that's not actually the case. And
no, it isn't.
Yeah, no, it's not at all. And I was actually speaking to Miguel, and I was saying to him that, look, I'm trying to do the best work that I can. That I don't really have, I don't really have that much success rate. My conversion rate wasn't particularly high. And he sat down with me, and as you know, he's a very giving person. He's very open with
Yes.
However he can help you, he will help you. So he went through some very simple communication skills with me. My mind was just blown. And he actually said, Pav, I've learned a lot of this from Paul Homoly. And that's when I started to research you. I looked at your website. I bought your books. I bought your audio series. And even from just your books and your audio series, Paul, it completely transformed how I spoke to patients. And then obviously when I had coaching with you, it just took it to another level as well. And please correct me if I'm wrong, but you've had quite a lot of extensive training with Pete Dawson, and you had been placing implants for quite a while, and then you moved away from clinical dentistry, and now you're coaching, and you're the author of a number of different textbooks, and you are also a professional speaker as well. So actually listening to
it's all kind of
yeah,
it's all kind of wrapped into one.
Absolutely.
Yeah. Well, I graduated from University of Illinois in downtown Chicago. Pav, I went immediately into the United States Navy. That was one of the best things I ever did, was join the Navy, become a Navy dentist. It really got my hand speed, got my confidence going. My first practice was in a small town in Western North Carolina called Hildebrand. I immediately rolled into Dawson Institute, the Pankey Institute. Dr. Carl Misch, probably one of the renowned names in implant dentistry. He and I were buddies. He and I started implant dentistry about the same time. And Carl invited me to become a faculty member at his Implant Institute in Dearborn, Michigan. I taught implant reconstructive dentistry, the surgical and prosthetic aspects of it, for about 10 years. But it's funny you should say about how you believe that, hey, people are just going to line up outside your door for this treatment. I discovered that the students who are going through the Institute's terrific, and it still is, Pav. A lot of the dentists were coming back to the second and third sessions saying they're not doing much. And they've got the training, they bought all the instruments, they have all the overhead, right? They did all of that, but they couldn't connect with patients. Because we're dealing with hefty price tags here. Cases now can easily exceed $10, $15, $20, $30, $40,000, right? Yeah. What is that in pounds? What's $30,000 in pounds?
It's probably about £24,000, £23,000. So they're big numbers. They're big numbers.
That's a big number. And so the more I looked at that, the more I realized that, and I wasn't having that issue. I had the opposite issue. We had to find time to put patients into practice. Well, one thing led to another, and yeah, it's a good problem to have. I started producing audio programs. I wrote some simple textbooks, some white papers, some study guides, and one thing led to another. And ultimately, I began to really focus on helping dentists build implant and reconstructive practices. I did that for about 15 years, in addition to practicing dentistry, in addition to running a commercial laboratory, in addition to raising a family. So I was like, every direction was up. And in 1995, I suffered an eye disability to my right eye, which really forced me to sell my practice. And so since 1995, I've converted over full time to what I'm doing today, which is teaching online programs, helping dentists do more of the dentistry they love. That's what it really boils down to. Because, Bob, when you're doing what you love, it doesn't feel like work so much. Sure, at the end of the day, you're going to be tired. You'll be physically tired, but you're not going to be stressed out or mad or crazy if you're doing the work that you really enjoy. So that's really where I'm focused now. And you and I crossed paths, I don't know, many years ago, probably 10 plus years ago. And over the years, we kind of kept in communication. You enrolled in the online program. You got the new version now. And I thought, it's time for us to reconnect. So this is a thrill doing your podcast. I look forward to helping your listeners.
It's just speaking to an old friend. So it's great. It's absolutely fantastic.
It is.
So Paul, it's it's the verbal skills that you taught me, I still carry to this day because they are so powerful. I've had communications training with numerous different people. Sometimes that communications training sometimes felt forced. It sometimes felt unethical. With yourself, it was very different. It was very, I think the best way to describe it, it was clean, easy, and patient friendly. And
yes.
I think one of the things that I found as well is, and I still see this a lot, particularly with younger dentists. And the only reason why I see it is because my senses have been refined because of what you've taught me. But dentists are too quick to jump into recommendations without understanding what's actually truly important for the patient. And we start to speak far too technical to the patients, and we know that. Yes. We know that we are giving them a better solution, but the patients, sometimes you can almost see them starting to switch off. And I see on forums where dentists turn around and they say, you know what, I'm really frustrated with this patient because they're not listening. It's like, well, actually, you know what? You need to actually understand what's important to the patient first before you make any recommendations. So if you could just expand upon that a little bit about your thought process with regards to how we should approach that, so people can start to understand a bit better, if that's okay.
Yeah, you're exactly right. The historical and the traditional way of managing patients simply doesn't work well when we're talking about advanced implant cases. So let's just back up a little bit in our careers. We graduate dental school, we might go through some early training, but when we're young dentists, we're doing modest care cases, a couple fillings, maybe a crown or two. And, patients are generally young. They want to get in and they want to get out. They're not, their dental conditions, Bob, don't have lifestyle altering conditions. The lifestyle is not altered by it. Dentistry is sort of, okay, it's time to get my teeth cleaned. Let's get in and get out. And a patient education style of the new patient experience works out pretty well. Patient comes in, checks in at the front desk. They go on back to get x-rays, maybe to get a scan of some photographs. They go to visit the hygienist. Hygienist cleans the teeth. After that, the dentist comes in, does an exam, charts the teeth, puts together a treatment plan, refers the patient to a treatment coordinator. Treatment coordinator says, here's your care. Patient says, okay. and they schedule the appointment and away they go. And you know what? That process probably is fine. But where that begins to break down is when those case fees get above $10,000. I'm going to speak in terms of dollars because, hey, I'm American, okay? I'm going to apologize for that right now, okay? When those case fees get above $10,000, when the conditions have lifestyle-altering properties. See, when you're dealing with partially and totally edentulous patients, there's lifestyle issues there. They can't eat. Their health suffers. They got intimacy issues. They don't like the way they speak. They don't like the way they look. And consequently, the risks are higher for these patients. Consequently, educating patients to conditions they already know about really doesn't do anything for them. The whole patient education model works best as a factor of influence for those modest care patients. Here's why, Pav. Because a modest care patient, they don't even, half the time, they don't even know they have a problem, do they? They can have class 2 decay periodontal disease. They say, Doc, I'm fine. You do an exam, you show them photos, you show them x-rays, and they go, oh, I didn't know that. So you've educated people. You've educated them into the issues. They're concerned about their issues, and they get them fixed. Now, let's take another example. Let's take a 60-year-old woman who's worn partial dentures for most of her adult life. The abutment teeth are beginning to loosen. She doesn't want full dentures. She's going through menopause. She's not confident in her appearance. Her diet is suffering. Her health is suffering. Her facial contours are changing. These are lifestyle hindering conditions. Now, that patient wants a much better, demands a much better, and deserves a much better new patient experience than simply sitting down with the dentist and having the dentist tell this patient everything that's wrong with her. I believe that, and hear me carefully, Pav, I don't want to be misunderstood here, but I think the whole idea of patient education as a factor of influence is horribly overrated when it comes to the complex care patient. These patients already know they've got problems. They may not know the individual pocket depths or the mobility of the teeth, but they do know they're unhappy. And what these people need is not so much education, but they need to be understood. They need empathy. They need to feel that the dentist is authentically curious and concerned about their condition. And that piece right there is where so many dentists, especially dentists, Bob, that are new to implant dentistry, you said it perfectly at the beginning of this show. They're too quick to get in there and offer solutions. They don't even know what the patient's problems are.
Yes.
Does that make sense what I'm saying?
It does, absolutely. And I have a very significant number of patients where, when we're talking about replacing teeth, where I don't mention the term dental implant until very significantly later on in the consultation process. And the patient already knows that, we've had the conversation with the patient, because patients don't want dental implants, they want fixed teeth. So I find out what exactly it is that we want, and I talk to them about fixed teeth. And towards the end, then I start to explain what the dental implant is. And I think something else that I still remember from your audio series, Paul, is that, and I completely 100% agree with you. I think the term, what was the term you used? You said the whoever came up with the term dental IQ needs to be shot, or something along those lines.
Yeah, I do say things like that. Yeah, low patient dental IQ. What is that about?
Because, and I remember the example that you gave. This, Paul, I've not listened to that audio series for years, but this is how it just stuck with me, is that raising the dental IQ doesn't really do much, okay? And to give you another example is that we all know what we should be doing in terms of fitness, health, blood pressure, body weight composition, etc. We all know that, and still so many of us don't follow those guidelines. And so relaying that to Dental IQ, just because you're making them aware of the problem doesn't necessarily mean that they want to have treatment done. And it's similar as well. It's we need to understand, firstly, is the patient aware they have a problem? And secondly, are they concerned about the problem? Because we all have those patients where, I've got the problem, I'm not bothered about it. And how you approach the care for that patient is different to how you approach the care for a patient who is bothered about it. So if you wouldn't mind just expanding on that slightly as well for us, that'd be very much appreciated.
Yeah, what you're bringing up is the distinction between recommending care for concerned conditions versus unconcerned conditions. Let me step back on this. The heart of my work is all about presenting complete care to all adult patients who have been through a complete exam. I'm not talking about patients that simply come in for the emergency appointment and you never see them again. But I'm talking about the adult patient that comes in, that goes through a complete exam. We have an ethical and medical legal responsibility of revealing to that patient all of their conditions, the consequences of those conditions if it's left untreated, and then recommend care for those conditions. And yet, Pav, you'll find this interesting. I've lectured to thousands of dentists over the last 25 years. And in my PowerPoint program, I can do anonymous polling. I can ask my audiences questions, and they can answer it with their smartphones. So it's anonymous. I asked them, how many of you are reluctant to offer complete care to patients out of fear of losing them to sticker shock, right? Mm-hmm. And over 70%, 70% of the dentists, Pav, that I've surveyed, I'm talking about 20 years of surveys now, 70%, on the average of 70% of dentists say they're reluctant to offer care. And the leading reason is because they don't want to blow patients out of the water. They don't want to lose the patient. In other words, they don't know how to talk to patients about conditions patients aren't concerned about. It's relatively easy to talk to patients about conditions they're concerned about. That isn't where the upset occurs. The upset occurs where for conditions the patients are not concerned. So let me take you through a scenario here. Pav, let's say you're my patient. Okay, yep. You're my patient, and you come into me and you say, well, doc, I don't like the appearance of these front teeth. Okay, and so then we talk a little bit more. Anything else going on? Well, it's been a while since I've been to the dentist. And so we'll have a little bit of a cordial conversation, and I'll get more into detail, but I want to get to the bigger point of concerned versus unconcerned conditions. Now, during the exam, I look at your front teeth, and sure enough, they've got old composites. They're discolored composites, probably would be veneers across the front. But I also noticed that you're missing your back teeth. You're missing your first molar and your second bicuspids bilaterally, upper and lower, right? You've lost a lot of back teeth. And you know what happens with patients when they don't have their back teeth. They end up chewing more on their front teeth. And this is your problem. So now I do my exam. I do all the diagnostics. And during the exam, as I'm examining you, I'll look at some conditions. For example, I always start the conversation, the post-exam discussion, with conditions the patient is concerned about. I'd say something like, Pav, I know you're concerned about the front teeth. When I see patients like you that have got fillings like this, typically without treatment, these fillings will continue to darken. And I know that's the big reason why you're in here. And you would agree to that. You see, that's called empathy. That's called understanding. So start with the patient's interest, not what you're interested in. And then I'd get to the back teeth. I'd say, Pav, I'm sure you're aware that you're missing back teeth. Patients who are missing back teeth end up chewing more on their front teeth and oftentimes destroy their appearance. Does something like that concern you? Okay. You see, I'm not telling you, Pav, you should replace your back teeth. I'm asking you if you're concerned about the possible consequences of not replacing your back teeth. So let's say you say, well, yeah, I didn't know that. Sure, I'm interested. So now when I present treatment from the standpoint, Pav, I know you're interested in better appearance in your front teeth, and I would recommend, and then I would make my recommendations. Then I would say, I also know that you're interested in replacing back teeth. The way we would do that would be like this. But now let's take the situation that we were describing earlier about during the exam. I say, Bob, I know you're aware that you're missing back teeth. You know, patients with missing back teeth typically find that they end up wearing out their front teeth because of that. Is that a concern for you? And you say, well, I don't know, I got this thing coming up and I really need to look better. And I don't know if it's in my budget, and you're giving me a lot of pushback. And then ultimately is, yeah, doc, but I need to think about it. All I would say is, I understand. Now let's present treatment. Now I'm going to present treatment for a condition that you're not concerned about. Listen to how I do it. I'd start like this. I'd say, Bob, let's start with what I know you're concerned about. That's the appearance of your front teeth. Let me make this recommendation that we remove the dark fillings, or remove that dark enamel, and we'll replace it with a new enamel-like material. Let me show you what you look like when we're all done. And then I use digital software or photography or something to demonstrate an outcome similar to yours. On other patients that I've done, I'd probably tell you a little story about the patient in the photo, that kind of thing. Then I'd say, Bob, another recommendation I'm going to make is about something that I know that you're not concerned about, and that's the missing back teeth. And even though you're not concerned, Bob, I want you to know that I am. And when you're ready, my recommendation would be to place dental implants, and then I would talk about dental implants. Notice that I still recommended complete care to you, didn't I?
Yeah.
I still recommended complete care. But Bob, when I said to you, I know you're not concerned, but I want you to know that I am, and when you're ready, did you feel any sales pressure from me? Did you feel like I was pushing you at all?
Not at all. And Paul, this is one of the things that, as you were explaining, I was actually going to come back to, is some of the other communication courses that I've gone to, is what they do is they get you. They do a number of things. Firstly, they do what's called active listening, where you listen to a little bit of what the patient says, then you repeat it back to them. Now,
sure.
If somebody were to try that on me, because I'm aware of communications type skills, it comes across actually quite patronizing. And I think the other thing that some courses do is they constantly try to find out what the barrier is to the patient wanting treatment, and then you try to break down that barrier, but that then becomes high pressure sales. Whereas what you're discussing at the moment is you're discussing finding out what the patient is interested in and what the patient's concerned about, but secondly, laying the pathway open for the patient to accept as much treatment as they want, but understanding what the treatment recommendation is as well. So what that does is it opens up the gate for treatment with zero pressure. And I hope that everybody who's listening to this can see the difference between the two, that the way that Paul was explaining it is there is no pressure there, and it's genuinely listening to the patient and what they want to achieve. So I do completely agree with you, Paul, when you were discussing that, I felt completely comfortable. I didn't feel like, I'm under pressure. There was no sales involved in that. So yes,
no sales. Pav, I have sat through those same sales seminars here in the States. You get some person that's, been selling patio furniture or cars, and they decide they're going to teach dentists how to sell dentistry. They haven't sold 10 cents worth of dentistry. Now they're telling us how to do it. Okay. And when I was young, when I was in practice, I'd go to these seminars, how to overcome patients' objections. Yes. Right. Yeah. And a patient would say, "Whoa, boy, $1,000 for a crown. Boy, that's pretty expensive." And we were taught to say, well, don't think of it as an expense. Consider it an investment, right? Or they would say, boy, that's a lot of money. I said, well, if you don't go ahead with treatment, it's only going to be more expensive in the future. If you'd like to save some money, doesn't it make sense for you to go ahead with treatment now? And let me tell you how I feel about it. I hate everything about it. Yes. Once, and here's the deal. The most popular profession worldwide are teachers. The second most popular profession are salespeople. So chances are your patient, Bob, is a salesperson, used to be a salesperson, is married to a salesperson, or best friend's a salesperson. And when someone is aware of sales tactics or communication tactics like you are, Bob, and when they hear one being used on them, pow, you instantly lose credibility. Instantly. And you're just toast. So, getting back to concerned versus unconcerned conditions, when you can present care for concerned and unconcerned conditions, that combination constitutes complete dentistry. Complete dentistry is two parts, concerned and unconcerned. And it's this unconcerned part that people get angry about and leave the practice. Not this part, but this part. So what you do is, first of all, you have to learn they're not concerned about it. Many dentists don't do that. They just they're going to educate the patient into being concerned about it. That doesn't work, not at the $20,000 or $30,000 level. It might work at the $100 level, but not at the $30,000 level. So you simply ask, does that concern you? And if they say, well, I don't know, this or that, don't argue, don't educate, don't try to overcome, just acknowledge it, say, I understand. Now, when you go into treatment presentation, you see, it's not our responsibility, Pav, for them to accept care. It's our responsibility to offer it. Yes. But offer it in such a way that even though patients may not be ready, they'll never forget how well you offered it. And when they become ready, they'll return to you. How many patients, Pav, how many patients of yours have come back maybe a year after you saw them? That you did an exam, you presented care, it's a big case, they go, I want to go home and think about it, and then you never see them again. A year later, they walk in, waving the treatment plan, saying, I'm ready. How often does that happen to you?
It happens a lot. And
it happens a lot, of course.
Yeah, particularly with the bigger cases. I think a lot of patients that they want to have the treatment done. They're not ready for whatever reason. It may be that their finances aren't right. They haven't got a problem with the overall fee. Rather, it's just I just can't afford to have it done now. And as you said, they'll walk back in 3, 6, 12 months later, saying, right, I want to start right now. So again, one of the most powerful things that you taught me was really starting to understand. Well, find out what the patient is aware of, because there are so many things out there that the patients are not aware of. And a big example of this is, and every dentist out there will be able to relate to this, is Perio. The number of patients who come into our practice where they have severe Perio issues, but they're not in any pain. They're not even aware of it. And all of a sudden, you have a new patient come into the practice, and you're turning around and saying to them, firstly, we need to do full mouth debridement. Then we're going to review you after 3 months' time. If in 3 months' time it's not resolved, we're possibly going to look at doing surgery. And the whole time, the patient sat there going, hang on, surgery? I don't have any problems. And there are ways of questioning patients so that you're bringing their awareness to the front without putting them under pressure. And I think that is very, very powerful. So yes, I do agree with 100% with what you're saying. Is we need to understand what the patients are aware of. Then we need to figure out whether or not they're concerned about it. And then, as you expressed, we have to present holistic care. And what the patient then decides is the patient's decision and responsibility. And I see a lot of dentists. I see a lot of dentists taking that responsibility onto themselves. I'm just like, hang on, this is the patient's issues. It is their problems. As long as you've done your part, you've done the best that you can.
Let's talk a little bit about Perio, because that's something that comes up a lot. So let's talk about, and let's go back to your case, okay? You're concerned about your front teeth. That's what you said you're concerned about. You're missing some back teeth, but also you've got some perio creeping around your teeth, okay? And you're not aware of it. You're not aware of it. And so the way I would approach perio would be like this. When I recommend your periodontal treatment, I know that's not your chief concern. I mean, how many patients come into your practice, Pav, where perio is their chief concern?
Not many.
Not many. Unless you're a periodontist, most general dentists, patients are coming in with toothaches or aesthetic issues or replacing teeth, or they need fillings. And perio is kind of like a necessary evil in patients' minds. It really is. And I'm not trying to diminish the importance of periodontal treatment. I'm just saying it's not on the top of the patient's list of things. Now, a good way of making perio more to influence patients better with perio is to link the benefits of perio not to pocket reduction, decrease oriflora, diminish probability of systemic disease, but rather link it to what the patient is concerned about. And in your case, it'd be the front teeth. So for me to recommend perio would sound like, during treatment presentation, I would say something along the lines of, Pav, one of the things that I talked to you about during the exam is that gum infection in your mouth. And you mentioned that you weren't aware of it, and you're not so sure whether you're concerned about it or not. I want you to know that I'm concerned, and I want to tell you why. I don't want the gum infection to spread to the front teeth and ruin their appearance. And that can happen. Gum disease spreads from tooth to tooth in the mouth. And we're going to do a real good job for you restoring your front teeth. I don't want that perio to ruin what we're doing. When you're ready for the perio, you must let us know. As a matter of fact, sooner than better. Does that make sense, parent? So I link it to what the patient is concerned about, right? And that's just a matter of knowing what they're concerned about. If they're not concerned about the back teeth, I can do the same thing. Patients with back teeth chew more on their front teeth. We're going to do a good job restoring your front teeth, and replacing your back teeth will help preserve the appearance. Right? So it's those types of things.
Yeah, it's just, it's a very subtle art form, but it can be learned. And it's one of those, I refer to it as soft skills. So the hard skills are the actual physical doing. That's the placement of the implants. That's the actual surgical. That's the endo, whatever it is that dentists are doing. But the most profound effect that anybody will have is when they start to hone their soft communication skills, because then you can really start to help patients on a level where you wouldn't have been able to help them before. And here's the other thing as well, Paul, is, as you said, it's when you make these treatment recommendations, when you try to figure out what the patients are bothered about, the number of patients that I see who've had teeth missing at the back for years, nobody's actually ever asked them whether they actually want them replaced. Or when you start to open up these discussions, the patient's like, I didn't even know that was possible. And you're like, okay, so you've been walking around for 5-10 years without these teeth towards the back. You're struggling to eat, and nobody's ever asked you if you want your fixed teeth. So yeah, the soft skills are incredibly important.
In the States, we have, I would show it to you, but it's in the other room. We have a big, thick magazine that comes like once a quarter. It's called Dental Product Shopper. Maybe you get that there in the UK too. And the dental product, it's probably close to 90 pages. And it's a beautiful magazine. And this morning I was eating breakfast, I was flipping through the pages, and all of the ads and articles, 99% of all the ads and articles are about the hard skills. Oh, here's a new scanner. Here's a new impression material. Here's a new matrix band. Here's a new operatory light. Here's a new handpiece. Here's a new this. Here's a new that. And there's almost little or no mention about services and products that will actually help dentists influence patients to accept all of this stuff. The soft skills, as you related to it, simply they're not sexy enough for dentists to be interested in it. I just got off the phone a few hours ago with a dentist that's doing 40 to 50 implants a month. And I asked him to describe his new patient process. And it has very little to do with patient education. It's almost all about the relationships they have with patients. And so what is a relationship? A relationship really boils down to what are the emotional outcomes that patients experience. For example, Pav, I'll ask dentists, I'll say, tell me about your new patient experience. And they go, well, we do exams, photos, and scans. Then the hygienist sees them, cleans the teeth. I come in, I bless the case, treatment plan it, give it to my treatment coordinator, and away we go. And there's a word that describes that new patient experience. Here's the word. It's called ordinary.
Yes.
It's an ordinary experience. And the truth of the matter is that technology, especially in the last 10 years, Pav, has kind of leveled the playing field among dentists. You see, it used to be only very senior practitioners and specialists could do all-on-4 restorations, multi-unit restorations, right? But now, general dentists are doing all-on-4. General dentists are doing full mouth reconstructions. Why? Because of digital technology, improvements in dental materials and bonding materials, better porcelains, better diagnostic materials. So what it boils down to, you're no longer special because you do implants, ortho, and complex restorative care. A lot of people are doing that. And the differentiator among dentists used to be their technical range. That's beginning to go away because everybody does cosmetic dentistry. Everybody does implants. Everybody's doing align orthodontics. And the differentiator is those moments that patients experience with you that give them the feeling they'll be well cared for. I mean, you think about it. One of the most important things that patients need to experience in the new patient process is that it needs to be a likable experience. Now, that may seem like common sense, but think about it. What's likable about the new patient experience? Are scans and study models likable? Are x-rays likable? How about this one, Pop? Is perio probing likable? No, they're not. The most likable thing about the new patient experience is the relationship the patient builds with the dentist and the team members. And yet, you ask most dentists, what's the first thing you do in your new patient procedures? Well, we take diagnostics, photographs, and scans. You see, they're missing the opportunity to make a surprisingly likable event out of the new patient procedure. Big difference.
And once you connect with a patient, it becomes much easier to understand what their goals are. I think before I started coaching with yourself, Paul, is I remember I had an offer on. I think I was doing 6-month smiles at the time, and I remember Google searching about my own practice, and I got flagged up on a forum, and this young lady had been in to see me, and she'd gone back onto this forum, and she said, "Don't bother going there. The only thing that this guy is interested is talking about how good he is and shoving his certificates down your throat." So I came to the realization, what, patients do not care about your technical skills because they have this presumption that you're capable of doing it. What patients are bothered about is how you make them feel when they're around you. If you can make them feel relaxed and comfortable and listened to, all of a sudden you've got your foot in the door. Then you can really start helping patients.
That's the first step right there. It's called likability, empathy, advocacy. That's the trick right there. There's no question about it.
So, Paul, obviously, I've alluded to this a few times already, and I'm I'm just conscious that, we could literally talk about this for hours because I know that
I know.
have this.
How long have we been talking here? I haven't not been keeping track of the time.
40 minutes already. So.
Oh, wow. Okay.
Well.
I think we should wrap it up.
Yeah. I was just about to say, Paul, I think if we could just spend a few minutes, and if you wouldn't mind just talking a little bit about the books and the audio series that you have and your website and kind of like the services that you offer, because I'm sure that those listening now, they'll have already been like, well, actually, you know what? This makes sense. So where people want to learn more, firstly, I can highly recommend, and in fact, I would recommend anybody who's doing dentistry should buy Paul's books and read them, because it will change the way that you do it. And buy his audio series. And I'm not getting any kickbacks or anything along those lines. Paul and I are friends, and he's been looking after me for a number of years. But what I'm trying to express, the way that Paul teaches communication is a very natural process, as you've already heard. So, Paul, if you could just spend a few minutes just explaining to us about the different books and audio series, etc., that you have. And for anybody who's interested, I will also be posting links to Paul's website in the podcast description as well. So we will have...
outstanding. Yeah. Thanks for that, Pav. I've written 5 books on the whole process of communication. 3 of the books are specific to dental. 2 of the books are about communication in general. And I would say to your listeners, Pav, for those who are interested in learning how to do more of the dentistry they enjoy, experiencing more treatment acceptance, having less stress, I would recommend enrolling in the online program called Making It Easy for Patients to Say Yes. You've been through that program, Pav. Yes. And Making It Easy for Patients to Say Yes, the online program, it's very complete. I've got videos. I've got staff training tools. It's really a turnkey program. You can access it on my website. It's my name, www.paulhomoly.com. Look under Case Acceptance Training, the online program, Making It Easy for Patients to Say Yes. And I would say, Pav, start there. Yeah. Once you're complete with that, then you'll be at another level of understanding. That's when I believe my book by the same name, Making It Easy for Patients to Say Yes, would make more sense for you. But I would start with the online program. And who knows, Pop, when this virus thing goes away, they won't let us Americans in Europe yet, right? We're quarantined. But once this virus threat goes away, chances are pretty good I'll make the trip across the pond. I've been threatening to visit you for many, many years.
Absolutely.
So I'll make the trip across, and maybe you and I can do some stuff together. I think that'd be fun.
Yeah, I think as well, Paul, I'd absolutely love for you to see what we're doing at Evo Dental as well. That's the clinic where we just do full arch treatment, and the workflow that we have there is just incredible. And we're literally right across the road from Heathrow, so it'd be very easy.
All right, nice. It'd be easy. It would be easy.
Yes.
Outstanding, Pop. Hey, I've enjoyed this. It's good to talk to you again. I love your energy. And now that I've got all your links to your podcast, I'll follow. I'll kind of be looking behind your back to see the other cool things that you're doing here.
Yeah, but I can't wait for you to come over, Paul. I know some great restaurants. We'll go out. It's just, fingers crossed, just a few more months to get past this. Past the bulk of the virus, and hopefully I'll be seeing you very soon. But thank you very much for your time today, Paul. It's been very much appreciated. And it's as always, it's a pleasure. I've learned more from you again, and you're absolutely right. I've enrolled onto the latest version of Making It Easy to Say for Patients to Say Yes, and I'm going through that at the moment as well. It's a fantastic resource, and I would recommend it to anybody, whether they're doing implants or general dentistry. I think it's fantastic for communication skills. So yeah, absolutely, yeah.
Okay, my friend. Hope to see you soon. Bye now.
Thanks, Paul. Okay, take care.